We are at the Hayes Convention Center at the 2023 iwCLL meeting with Federico Caligaris. And part of this project has been not only to attempt to record the history of iwCLL, but also to get at the intellectual history of CLL. And rightfully or wrongly, it was conceived that the Rye-Benet medalists might be a starting place, not to say that there aren't other leaders.
Sure.
But that's what I've been working through. And early on, Emilia Montserrat told me I better hurry up and get going because people aren't living so long. So, anyway, I remember in one of our discussions that you told me the story of when you first went to meet David Galton. And I was wondering if you could remember to retell that story.
Yeah, that's a very interesting story because I met him first, it was 1981. I was in London working at the Department of Immunology of the Royal Free Hospital, department which was chaired by George Janussi, and my project as a postdoc was to try to develop monoclonal antibodies against CLL. And as a part of the project, I was in touch and collaborating with people like Mel Greaves, Daniel Katowski, and David Galton. David Galton was seen as a sort of a magician because he could see through the microscope things that no one other human being could see and make perfect diagnosis. So one day I was asked to go and have a chat with him in his office at the Hammersmith Hospital. And frankly speaking, I was very, how to say, well, shy, because he was Professor Galton, and I would like to become a scientist. So David was extremely kind, nice, and we started talking in the sense that he asked me the obvious questions. What are you doing? Which is your project? What are you planning to obtain? And so on and so forth. But all of a sudden, he stopped talking and looking at me. He turned his head toward the window, and he told me, see, that's a ladybird. You know what ladybirds are? And I told him, well, yes, more or less. So he started teaching me about, he was a great bird watcher besides being a great clinician scientist. So we had a very long chat. I guess it was a couple of hours with some interruptions due to, that's a red robin. And so it was very nice, and actually he was wise, because when I told him what I was going to do, he always asked very politely, very nicely, but very sharp questions. And thanks God, I had already been mulling over the same question so I could answer to him. So it was actually a bi-directional chat. That is when I first met David Galton.
Yeah, he certainly enjoyed a reputation for being able to recall the name of his patients based on
Absolutely.
their bone marrow aspirate
Yes.
morphology.
Yeah, absolutely correct. He had a huge experience coupled with a great humanity.
Yeah. I remember him also telling me about the slide, I guess it would be the Hammersmith slide collection.
Mm-hmm.
I forget. There was a fellow who worked out the evolution of. She put 4 papers together on essentially reviewing morphology slides and the natural history of the PL component.
Right.
I'm always embarrassed when I forget someone's name. I even have at one time I had a cell lane from her. But he said that eventually the building engineers came around and said they couldn't save slides anymore because the floor was starting to fall down because the slide collection was so heavy.
I can imagine, because he was really a great person.
And going more so to you now, when the citation that was with your award had to do with the discovery of the human normal B cell equivalent of CLL, the CD5 B cell.
Right.
Could you talk about that a little bit?
Well, it is interesting because I was in London, and my project was to develop monoclonals against CLL cells. So I used CLL cells to immunize mice, and then to obtain the monoclonal. And then I had to screen the monoclonal obtained. And I was baffled because the best monoclonal that I retrieved was positive on T cells. So I thought, what have I done wrong? And then it was obviously positive both on T cells and on CLL cells. So later on it became apparent that it was CD5. But then the question was, is there any normal CD5 positive B cell? And to try to answer that question, I made a lot of experiments on peripheral blood B cells, but I was more interested in the idea that the B cells I was looking for were in the tissues. That is why we utilize lymph nodes, or more frequently, for obvious reasons, tonsils, because tonsils could be easily provided, while lymph nodes were a real nightmare. And so in tonsil, the point was that I was making cell suspension, but also tissue sections, and staining with anti-immunoglobulins and with my monoclonal. At the end, I found a tiny proportion of cells which were Ig positive and CD5 positive, and they were at the edge of germinal centers, close to the mantle. And this, in a sense, was finding that CLL cells had somehow normal equivalent cells that are present especially in the tissues, and in a precise location that made me start thinking that that was an environment rather unique. So that was the reason why I started working on microenvironment. And it was also interesting that these cells were very frequently in cord blood. So cord blood B cells, most of them were CD5 positive. And then they simply disappear, or, I mean, in the peripheral blood, very few cells have that phenotype. But what interested me was the presence in the tissues and the idea that they might live in a microenvironment potentially conducive or helpful for either the development or the progression of, or favoring the progression of CLL.
CLL.
Yeah.
Boy, that just strikes me that I think we forget, in this day and age, I would think that most people would forget what a contradictory finding that was, in the sense of a T cell marker being present on an IgG positive
Correct.
B cell. It caused a lot of mind wrangling for quite some time. And then the whole cord blood story was really fascinating. And of course, as always, there's usually some mouse murine findings that are contradictory.
Absolutely.
There was, isn't there an abdominal peritoneal study?
Right.
A tradition of murine have those cells?
Yeah, that is true, and that was, and also aging mice develop a very high number of these cells, which in a sense was reassuring, considering that CLL tends to be a disease of, let's say, the elderly. And what was interesting was also the fact that, as you said, it was a T cell marker on B cells. So I started thinking that these cells might be cells that think B but speak T. Okay, so they are cells with an interesting capacity of being, let's say, different in brackets.
I think I didn't appreciate it. Well, thinking now back and seeing the papers, the sectioning that you would have done would certainly lead to the localization
Right.
at the periphery of the germinal center or at the mantle level. What's the relationship between, say, the CD5 normal B cell and a primary aggregate that we might find, say, in a bone marrow biopsy?
Now, let's put it that way. What struck me was that when I analyzed normal tissues, I could find CD5 positive B in lymph nodes or tonsils, in other words, in peripheral lymphoid tissue, but not in the bone marrow. But when we analyzed bone marrow of patients with CLL, what was interesting was that the clusters of CLL cells were easily recognizable because of the CD5 expression, and they were all clustered around the follicular dendritic cells. But as time passed by and the localization of CLL in a marrow was no longer due to nodules but became disseminated, you could find not one single follicular dendritic cell. So this was how we started thinking and then discussed, say, with Frida Stevenson, the fact that, those follicular dendritic cells unlikely were there just by chance, because it was not one sample, it was a lot of samples that we analyzed, different patients. So that we started thinking about the possibility that there was some sort of antigen presentation that might allow B cells to be tickled and proliferate and grow. That was the way we were reasoning those days.
So in a way, what we maybe take for granted today in terms of the focus on the microenvironment, which, correct me if I'm wrong, I have the impression that it's focused primarily on the lymph node. It sounds like to a certain extent it might have originated in the bone marrow.
Well, not exactly. When I started working, the idea was that CLL, as all leukemias, must be a bone marrow-derived malignancy. Okay. Now, all the data that we gathered led me to conclude that more likely CLL is a lymphoid tissue-derived malignancy that then is a capacity to colonize the bone marrow. So the bone marrow invasion is, in my view, and I think that many other people are thinking the same way, the bone marrow is a secondary colonization, it's not the primary site. And that the events, the most important events, occur in peripheral lymphoid tissues.
Yeah, I concur with you, and I learned it primarily the first way you said it, and I think it took me a long time to get my head around the fact that I was wrong. It seems like you probably did it faster and more sophisticated.
Well, it is simply, as it always happens in science, one thing is leading to another. So it is not a matter of being fast. It's a matter that you accumulate information and data. Some are published, some are not, but they are part of what is in your brain and helps you to think. Let me tell you one thing that I never published. I had a friend who was a nephrologist, and he was doing peritoneal dialysis. So one day I told him, well, it would be interesting to see whether we see cells in the peritoneal lavage. And just by sheer chance, a patient of mine had a renal problem and underwent a peritoneal dialysis. Mind you, he was not an aggressive CLL. He was one of those guys that came repeatedly every 3-4 months to the outpatient because he stayed with 30,000 YBC. Stable. But he developed this renal problem, which was apparently, the nephrologist told me so, totally unrelated to CLL. But I took the peritoneal lavage, it was full, incredibly full of CLL cells. So then I analyzed also the peritoneal lavage of other patient, but kidney patients, not CLL patients, and you could find CD5 positive B cells in the peritoneal lavage. So the issue that these cells are tissue related or tissue oriented or like to be in the tissues, to me is rather solid.
Tissue derived.
I think it is, they are tissue derived and they like to stay in the tissues.
I never know how to quite ask this next question, so I start the discussion with MBL,
Mhm.
the monoclonal B-cell lymphocytosis. And with you, I think maybe I could even jump to nodal MBL. Does it occur in a single lymph node? Or do we have to have a whole lymph node region? What makes it stay small lymphocytic lymphoma, and what makes it CLL? And if it's CLL, is it diffuse?
Yep.
So if we biopsied every lymph node in somebody who had early CLL, they would have partial MBL in each lymph node?
Well, frankly speaking, I never had the possibility of investigating and trying to answer such a question. What I can say is what I think, which does not necessarily mean that it is the truth. I think that MBL if all people with MBL could live up to 300 years, all MBL would become a CLL. So it takes time. In some cases, it takes a rather limited amount of time. In other, it would take so long that the patient will never in his lifetime develop CLL. But having said that, I think that MBL must be born in the lymph nodes.
A single lymph node?
Well, we always think that leukemias are monocentric, or so I think that they are born in a single lymph node, and then they may have or develop the tendency to move, to circulate, and therefore to colonize other lymph nodes. Now this brings in the issue of which might be the most likely lymph nodes. And in my view, again, it's just a view, I have no proof, I think that the lymphoid tissues of the gut is a potentially very interesting target, a candidate to be the node where the whole story starts. Because clearly the lymphoid tissues in the gut are exposed to a whole range of potential antigens, including the microbiome. I mean, so I think that we are just at the beginning of a long story.
Maybe an equivalent parallel for the cervical adenopathy, a cervical biome.
Yes.
And I don't even know if there would be a separate pelvic biome.
The people who are working in the field of microbiota, they claim that it is highly likely.
Okay. Well, I think that, how are you finding the meeting you've been to quite a few iwCLL meetings. You've probably been to all 20.
No, I guess I've been only to 19. I think that this meeting is a superb meeting for different reasons. First, a lot of young people, and young people presenting fascinating data and presenting very well, I mean, very professionally. This is one important aspect. The second important aspect is that it is not the meeting where only the usual suspects are speaking, but we have a lot of newcomers coming from other fields. So this might be of interest and of importance because it's sort of a cross-fertilization that I think is important.
Yeah. Well, thank you. I think it's time to stop and